In terms of bad habits, the Eastern Shore is very southern in its nature, so we have a high incidence of smokers. Lung cancer is, particularly a disease that we see predominantly in smokers. I think our rates of lung cancer are consistent with what you would see in the southeast of the United States, and probably less than you would see in, say, Baltimore or Anne Arundel County. The numbers that I've seen lately for our catchment area looks like we diagnose between 90 and 100 new cases a year in the last 5 years here for our five-county catchment area, which is, Talbot, Dorchester, Caroline, Kent, and Queen Anne's. Overall, lung cancer is still a number one cause of cancer death in men and women both, and it accounts for about 25% of cancer deaths overall. That's true. This is a real paradigm shift in terms of lung cancer screening. We have had over the years looked at routine chest x-rays, sputum tests. Nothing really turned out to be helpful in terms of decreasing mortality from lung cancer until we got this lung cancer screening program. This came out of a study that was published in the New England Journal in 2011, I believe. They took over 70,000 smokers and ex-smokers and they did CAT scans of their lungs once a year. And after 5 years, they concluded that study because it looked like we could decrease the mortality or death rate from lung cancer by 20 to 30%. There was also about a 7% decrease in all-cause mortality. So we do find things when we're looking at the lungs that make a difference in people's life expectancy, like cardiac disease, kidney cancers, liver cancers, thyroid cancers. So there are things that we're not particularly looking for that we can find that we can make a difference in as well. But this is a big shift, and so if you look at before lung cancer screening, if you look at the presentation of lung cancer, 70% of people that presented because of symptoms were late stage disease, stage 3 and 4 disease, which, no offense, we have treatment for, but not curable. So when you look at the lung cancer screening population, 70% of the new cancers diagnosed are stage 1 and 2, and those are potentially curable. So it's a big shift since we've been doing this.
Yeah, go ahead.
I think completely agree. And while lung cancer is one of the deadliest cancers, picking up earlier lung cancers is also, it's a game changer because as Dr. Oliver pointed out, we used to pick up lung cancers mostly stage 3 and 4. But if we're going to compare, historically, obviously, stage 3 and 4 patients did, even those patients did worse than they do today because of more advanced, mostly systemic, immunotherapy drugs have been a game changer in those patients. As a radiation oncologist, radiation has been a game changer also in the early stage because who gets lung cancer? Smokers. Not all smokers are medically fit people because they also have other pulmonary diseases. So not all of them can have surgery. Surgery was always a curable option. If you were fortunate enough to be diagnosed with early stage lung cancer and you couldn't withstand an operation, you really didn't have a shot at cure. When I first started out, I remember even in very early, late 90s, early 2000, I would tell patients, early stage 1 lung cancer, I can treat you with radiation, but we still can offer you about 50% control rate. That was not so great. Today, with our newer technologies, with something called lung SBRT, which is stereotactic body radiotherapy, we're able to give ablative doses, very high doses of radiation in 3 to 5 treatments, and that has about a 90+% control rate in tumors that are 2 centimeters or smaller. Yes, the control rate goes down as the tumor size goes up, but again, making a case for lung screening and picking up these tumors earlier. Most of our lung cancer patients were smokers at some point in their life. And some people, and there's probably some genetics at play because some people can smoke all their lives and have no issues. Others can smoke for a very short period. and develop lung cancer, head and neck cancer. There's all sorts of other cancers that are associated with smoking. Besides smoking, there's, secondhand smoking. I would put that as number two. I know when I lived in the Midwest, we used to have to do radon testing before buying a house. Radon is, risk factor prior, especially at a very young age, if you are exposed to radiation. But in those patients, again, we find that the smokers have a higher risk than non-smokers.
The screening program has pretty strict criteria, mostly driven by what Medicare decided they would cover, and all the other insurances filed suit. But the people that qualify for screening should be between ages 50 and 77 is the current guidelines. They have to have a 20-pack year history of smoking. So that's 1 pack a day for 20 years, or 2 packs a day for 10 years. You calculate the packs per day times the years. So 20-pack years of smoking. They have to be current smokers or have quit within the last 15 years. So if they quit 27 years ago, they don't qualify for the screening. I should say that nodules are extremely common. So when we're screening these people, about 35% of people will have nodules. 97% of those are not cancers. So we live in an area where there's a lot of histoplasmosis, which is a fungus that lives in the soil. So we see a lot of what we call granulomas, which are calcified nodules. Those are not cancers.
And not just for stage 1, but the stage 3 patients, again, there are our techniques in radiation have advanced. We learn from prior trials what works, what doesn't work. We used to give higher doses of radiation for lung cancer. Now we've cut back on the dose because one of the trials showed that the higher dose patients actually did worse, perhaps because of the dose to the heart. So there's always, and our newer techniques allow us to reduce the dose to the heart as well. So as we're making progress and these patients are living longer, it's more important to also make sure our therapies are less toxic.
It's calculated we have to scan about 320 people to save 1 life, but
like I've already said, when I see a patient with stage 1 that I'm treating, it's great to be able to start the conversation. Yes, I know you have lung cancer, but let me assure you, this is a very curable, and like I said, 90% of them are not going to have a recurrence in that spot. There are patients, again, where I've treated 1 spot, but then they will have a second lung cancer someplace else, which we can treat. It's not that we treated 1, so we can't treat the other. And the other feel-good stories are probably somebody who I see that I would not imagine them being around 6 months later. And then I see them in my follow-up clinic 6 years later because of the advances. So I had a patient who, when I first met him, he was doubled over in so much pain, and I treated him palliatively for a bony lesion. And then after that, I must have treated lots of different things. I treated actual lung lesions in him. I treated brain lesions in him. And again, even for the brain, we used to have to treat everybody with whole brain. Now we can do a lot of what's called stereotactic radiosurgery, where we just treat that spot. So all of those things, he had a very good quality of life. And for someone who I didn't think would be around 6 months, was around longer than 6 to 8 years.
Yeah.
I mean, you've said.
Well, we're making progress in terms of smoking cessation. So you can't smoke in restaurants anymore. You can't smoke in a lot of public places, thank goodness. And people are not smoking as much as they were. So the younger people coming up, we have more trouble with vaping, which is not associated with lung cancer. That's a whole different ball of wax. But not as many people are taking up smoking. And a lot of smokers, are between feeling ostracized when they go out in public, not wanting to expose their family to their bad habits. Cost, cigarettes now locally are about $16 a pack. That'll get your attention pretty quick. Somebody comes into my office and says, I can't afford, a $20 inhaler, and I'm doing pack and a half a day, you're spending $800 a month. on cigarettes, and they don't realize that, you know, because they go and they smoke. But you sit down and you calculate that for them in the office, they go, oh my God, and then they really want to quit. Got to put a plug into our local health departments because they all have wonderful smoking cessation programs. And that's part of the lung cancer screening is we talk to people about the need for smoking cessation, and we give them the option of, you know, the 1-800-QUIT line. But the health departments are fabulous, and it costs nothing to go to the health department, and they can help out with free medications for smoking cessation. So that's been a real bonus in this area. Program that we run locally, we take referrals from family doctors. People can call up and say, I think I want to be screened. We put them in touch with our coordinator who goes through and says, you know, what's your age, what's your smoking history, do you have previous, you know, that gets all the questions. You can't have a lung cancer screening CAT scan if you've had a previous CT within a year, so you have to wait a year and a day. So they go through all that criteria, and if they qualify, then we set them up. Myself or one of my partners will do the counseling piece of that, and then we have them get the CAT scan, and we call them with those results, and we, you know, once they're in the program, then they're automatically queued up for next year, and so we have the software to track them so they don't get lost to follow-up. That's one of the major problems in terms of people just ordering CAT scans, you know, from their family doctor's office. Nothing wrong with that, but they often get lost. So if you look at centralized programs where like ours, we have about a 70% retention rate. If you look at programs that are decentralized, in other words, people just ordering CAT scans here and there, it's about 30% retention rate. Yeah, so being part of University of Maryland medical system for us, we have availability of interventional bronchoscopy folks, so if they need biopsies of some sort, because we don't have all the newest robotic bronchoscopy equipment locally, so we partner with the various hospitals in UMS to get those procedures done for diagnosis and staging, and then surgical. We don't have thoracic surgeons here in Easton anymore, and so we refer those people for surgery up to Baltimore or Greater Baltimore or Washington Medical Center generally for surgery.